I'll be talking about congestive heart failure. There we go. Now figure out how to work the computer. I'm so sorry. There we go. Okay. So during this presentation, I'll be going over a few things. I'll be going over the definition of congestive heart failure. We'll talk about systolic versus diastolic heart failure. We'll go over the clinical presentation, the diagnosis, the etiology, and the treatment of acute decompensated congestive heart failure. And we'll also go over the treatment of chronic congestive heart failure. So apparently you've all been here since 8 o'clock this morning. So you're probably all very sleepy right now. So I'm going to try to keep you awake. So we're going to make this an interactive presentation. So we'll start with a case presentation. Mrs. HF is a 54-year-old female. She's presenting with a 10-pound weight gain over the last 1 week, dyspnea, orthopnea, PND, and lower extremity edema. She has a past medical history significant for hypertension, diabetes, hyperlipidemia, osteoarthritis. She's also had a history of breast cancer status post chemotherapy. She drinks alcohol, and she also smokes cigarettes. Family history is significant for hypertension, diabetes, and coronary artery disease. Medications include Actos, Zocor, Lisinopril, and she takes NSAIDs on occasion for osteoarthritis. Review her system, she complains of fatigue, weakness, cough, and she had her upper respiratory infection about 2 weeks ago. On physical examination, her blood pressure is 170 over 90, heart rate is 122, ultrasats is 92% of room air, her temperature is 98.2, and her body mass index is 42. HANT is normocephalic. Next, she has an elevated jugular venous pressure. Cardiac examination, heart rate's irregular. She's got a grade 2 over 6 systolic murmur. She's got an S3. Lungs, she has rales bilaterally. Abdomen, valve sounds are positive and distended. On extremities, she has 2+ edema. You can go back. So, what do we think Mrs. HF has? Congestive heart failure. Okay. Congestive heart failure is a complex clinical syndrome that can result from any structural or functional cardiac disorder that impairs the ability of the ventricle to either fill with blood or to eject blood. And what this leads to is a decreased cardiac output. Now, there are two ways by which a decreased cardiac output in heart failure can occur. It can occur via systolic dysfunction or diastolic dysfunction. But let's start with a normal heart. In a normal heart, during diastole, the ventricle fills with blood normally. During systole, the ventricle pumps about 60% of the blood out. That's how we get the ejection fraction of 60%. In a patient who has systolic dysfunction, the ventricle is enlarged and it's weak. And during diastole, the enlarged ventricle will fill with blood. During systole, the ventricle pumps out less than 40 to 50% of the blood, and this leads to a decreased cardiac output. With diastolic dysfunction, you have a normal ejection fraction, but you have a stiff and thick ventricle. So in diastole, the stiff ventricle fills with less blood than normal. But in systole, the ventricle will still pump out about 60% of the blood, but the amount of the blood is lower than normal. And the reason the amount is lower than normal is because you're starting out with less volume to begin with. So you also end up with a decreased cardiac output as a result of that. So that's the mechanism behind diastolic heart failure. You have a normal ejection fraction, where you have less filling during diastole, so you have less blood going out. And that's what causes the decreased cardiac output. All right. So now we suspect that Mrs. HF has congestive heart failure. Now, the clinical diagnosis of congestive heart failure, there's no one real test to diagnose congestive heart failure. It's largely clinical. So it's based on a very careful history and physical examination. So why don't we go back to our history and physical that we have on our slides there, and see if we can kind of bring up some of those clinical presentations that we see with heart failure. And Kevin is going to be our volunteer. Yeah, I think they have it in the slides too.
It's 3.
Okay, so looking at this clinical presentation, what are some of the presenting findings that she has that's making us suspect that she has heart failure? Any takers? 10-pound weight gain, okay. dyspnea, apopnea, PND, and edema. So these are your symptoms that she's having now, right? So I think we've kind of covered most of them. And then if we go to the next slide, now we can talk about some of the signs that we're seeing that are suggestive of heart failure. And what are these signs that we're seeing here that are suggestive? Someone mentioned the rails and exam. Okay. What else? The S3, very good. Okay. The increased jugular venous pressure. Okay. Anything else here that's there could be a silence, yes. S3. The murmur, yes, the S3. And then, of course, the edema of the lower extremities. Okay. All right, next slide. So basically, the clinical presentations of heart failure occur primarily as a result of excess fluid accumulation or from a reduction in cardiac output. The things that you see from excess fluid accumulation include your dyspnea, your apopnea, the PND, edema, and you can get pain from hepatic congestion, as she had talked about, and you can also get distension as a result of that. Now, from a decreased cardiac output, the most things you experience will be fatigue, weakness, especially with pronounced exertion. Now, this is a patient who has severe congestive heart failure, as can be seen by the increased jugular venous pressure. So when you're checking for jugular venous pressure, you want to make sure there's adequate light. You want to make sure the patient is at a 45-degree angle and the head would turn slightly to the opposing side. First thing you want to do is check for that venous pulsation and then look for the tip of the venous pulsation. Normally, in a normal subject, the pulsation shouldn't be any more than 3 centimeters above the sternal angle. This is about 8 centimeters. You can see the tip right there. So that's an indication that this person has congestive heart failure. We can't talk about heart failure without talking about the New York Heart Association. You've heard it a lot of times. And it goes through 4 classes, class 1 through class 4. A patient with class 1 congestive heart failure has no limitations during ordinary activity. Class 2 patients have slight limitation by shortness of breath or fatigue during moderate exertional stress. Class 3 patients will have symptoms with minimal exertion that can interfere with their normal daily activity. Class 4 patients, they can't carry out any physical activity. Most of these patients have muscle wasting. All right, so we've decided that HF has congestive heart failure based on her clinical presentation. Now we have to decide how we're going to prove that we think this is congestive heart failure. So what are some of the diagnostic tests that we'd usually like to order to kind of confirm our suspicion? A BNP, okay. Chest X-ray, okay. Echo. EKG. Anything else? Usually your labs, you know. Definitely labs, you know. All right. So of course you're going to start off with an EKG. It's very unusual to have a normal EKG with congestive heart failure. There'll be some signs of LVH, left atrial enlargement. You may find some arrhythmias. And with your blood test, the CBC can be useful because if there's anemia, it can suggest high output cardiac heart failure. If the CBC, if the white count is elevated, it could indicate infection, which could exacerbate heart failure. With the BNP, useful because hyponatremia can indicate the severity of heart failure. Patients who have severe heart failure tend to be very hyponatremic. And also, your renal function is important because it helps you in terms of managing your diuretics, and especially if you're considering starting ACE inhibitors, you want to know what their creatinine is. The LFTs are important primarily because they tend to be elevated with severe congestive heart failure because of hepatic congestion. TSH is important because hypothyroidism can cause heart failure or can exacerbate heart failure. And of course, the BNP. And I'll talk more about the BNP later. The chest X-ray is also very important, gives you indication of fluid overload. And of course, the echocardiogram. Okay. The BNP is a natriuretic hormone, and it's released primarily from the heart, particularly the ventricles, and it's released in response to stretch of the ventricles. BNP gets elevated. Okay. It's increased in patients with left ventricular dysfunction, particularly patients with congestive heart failure. And where it's primarily useful is in distinguishing heart failure from other causes of dyspnea. So patient comes in short of breath, you're not sure, is this pulmonary pneumonia or is it heart, the BMP is extremely useful. And so if you're not certain of the diagnosis, this is definitely a useful test to order. Okay. Most patients that have heart failure, their BMP levels are usually higher than 400. If you have a value less than 100, it's very unlikely the patient has congestive heart failure. So I think it's useful in terms of helping you rule out congestive heart failure. Just like a D-dimer would your PE. If you have a BNP less than 100, the likelihood of heart failure is less.
One thing, the lab has changed our value.
To pro-BNP,
Yeah.
Yes.
And the values are now like 5 to 900, and then once you're over 900, then that's considered elevated.
And that's because what they're measuring now is the pro-BNP, which is another, the natriuretic peptide, when it's cleaved into BNP and pro-BNP. BNP is the active substance, and pro-BNP is the inactive substance. And the reason I think the lab changed, I think, is because the pro-BNP has a longer half-life, so you're likely to detect it more. So the values are a lot higher now. I think it's about above 900 is considered abnormal for the pro-BNP, you know. And it varies depending on your age, your sex, and things like that, you know. So in terms of chest X-ray, the chest X-ray is extremely useful with congestive heart failure. So we can't look at a chest X-ray without knowing what a normal chest X-ray looks like. So this is a normal chest X-ray. You can see the heart. The heart size is usually less than half of your AP diameter. But look at this patient who has a cardiomyopathy. As you can see, this patient's cardiac silhouette shows cardiomyopathy. There's cardiomegaly, and there's some non-specific interstitial changes here. But definitely you can see this difference in the heart size between the two. Okay. This is a patient who has severe heart failure. And this patient has pulmonary vascular congestion with some infiltrates, as you can see here with these arrows. This patient also has a pleural effusion. And the reason to suggest that is, can you see this angle here? See how it's nice and clear? You can actually see the claustropenic angles. There's blunting of those angles here. And this blunting is because this is all fluid. Okay. This is another patient who's presenting with pulmonary edema. And they have what we call the classic butterfly distribution. As you can see here, these large perihilar opacities in this patient. This is classic butterfly pattern that you see in the patient who has pulmonary edema. Okay. Now let's see if we can get this to work. All right, so we probably should end short. And then click on each individual one, see if it works. And then let's enlarge it. No, I mean, okay, can we see? We may need the lights dimmed a little bit. Okay, I wanted to show you what a normal echo looks like so you can appreciate what one in congestive. Let's go back, play again. So this is the normal echo. This is the right ventricle. This is the left ventricle. This is the atria. And you can see the nice, good squeeze in the ventricle of a normal patient. All right, now we're going to do the other video. This is a patient with congestive heart failure. Can you appreciate the dilated ventricle? See the lack of squeeze here? The heart is just sitting, not doing anything. This is about ejection fraction of about maybe 10 to 15%. So you can see hardly any motion in that left ventricle. Okay. Now, if we're going to manage this patient with congestive heart failure, we need to know what's causing it. You know, we need to understand what are the possible potential causes of congestive heart failure. So we're all going to do some investigative work based on our history and physical. What are some of the things that we think could be causing Mrs. HF's heart failure? So let's go back to that case presentation again. And looking at our history and physical, are there any clues there? Hypertension, yes. If you look at her blood pressure was what, 170/90? So she probably has possible uncontrolled hypertension that could be a contributing factor. So hypertension. Diabetes, and the diabetes would be either from poor sugar control. Okay. Anything else here that's, and we can look at our physical. Hyperlipidemia, okay. Smoking, okay. Chemo. That's very good, especially, you know, chemotherapy. Some of these chemotherapies for things like breast cancer are very cardiotoxic, and they can decrease your ejection fraction and cause heart failure. Anything else here on this page here? Drinking alcohol, so you can get what we call an alcohol-induced cardiomyopathy. That echo I showed you looks just like someone who's been drinking for a long time. It can decrease your ejection fraction. So alcohol. Anything else on this page? The NSAIDs, yes. So actually, these NSAIDs have been known to cause fluid retention and can actually exacerbate heart failure. So if a patient comes in with congestive heart failure and they're on NSAIDs like naproxen or Celebrex, those are things you probably want to be withdrawing while you're trying to treat them for acute heart failure. Anything else here? There are a few more things that we can pick up here that are...
Didn't you say recent illness?
Yes. She had an upper respiratory infection 2 weeks ago, and a lot of times you can get what we call a myocarditis as a result of an infection. So infection itself can cause congestive heart failure and can actually cause a decreased ejection fraction. The good news about infection is that over time it usually reverts back to normal. Anything else here? What are some of the drugs, some of these medications that could exacerbate? Actose is a big culprit. Uh-oh. I'm okay. Actose is a big culprit. Actose causes fluid retention. So a patient comes in with congestive heart failure, you probably want to ask the doctor if they want to continue Actose because it will cause fluid retention. So I think we've covered most of the possible causes on this page. What about on the next, yeah, so I think those about, okay, some other clues here can clue us into some causes of heart failure. The murmur, exactly. So you can get congestive heart failure from valvular heart disease. For example, with aortic stenosis, the valve is so tight and the heart's trying to squeeze across this tight valve. After a certain point, the heart's going to fail because the pressure is so much. So valvular heart disease can cause that. Anything else on this page? There are a few more things on this page that can be clues. I'm sorry? Yes, those are kind of some signs that we have there. But what about possible causes of a diagnosis? The murmur can be valvular heart disease. A few more things on this page I think that's useful is the fact that the heart rate's 122. So you wonder, is the patient in AFib? Patients who are in AFib, especially when the heart rate is uncontrolled, when the heart's beating above 100 for a certain period of time, you're going to develop what we call a tachycardia-induced cardiomyopathy, to the point where the heart had been beating so fast for so long, the heart's going to fail. So arrhythmias are very common causes of congestive heart failure. So I think we've covered most of it. So we talked about, where are we now? We talked about chemotherapy agents, we talked about infection, we talked about uncontrolled blood pressure, alcohol cardiomyopathy. The way the hypertension, diabetes, and hyperlipidemia come into play is that they cause coronary artery disease. So by causing coronary artery disease, you can get ischemia of the myocardium and congestive heart failure. So diabetes and hyperlipidemia by itself may not necessarily cause congestive heart failure, but they increase your risk for coronary artery disease. Okay. So let's talk about the common causes of heart failure. I think by far the most common cause in the US is coronary artery disease. And after that is uncontrolled hypertension. There's something we call idiopathic, meaning we've looked at every possible cause and we just can't find a reason for it. And that's idiopathic cardiomyopathy. We talked about the valvular heart disease such as severe aortic stenosis, sometimes severe mitral regurgitation can also cause that. Okay. Of course, the less common causes are your endocrine causes such as your diabetes or your hypothyroidism. We mentioned the chemotherapy agents, the cardiotoxic substances can do that. Of course, your arrhythmias we talked about. And your viral infection, that's where that upper respiratory infection 2 weeks ago came into play, because viral infections can cause congestive heart failure. You can get restrictive cardiomyopathy. When you have severe anemia, you get something called high output cardiac failure. And also, this is very important, we get what we call peripartum cardiomyopathy. And it's rare, but when it happens, patients present with congestive heart failure and a very decreased ejection fraction. 50% of these patients will recover and 50% won't recover. The key thing you need to tell them is no more children. They cannot have any children more if they develop peripartum cardiomyopathy. All right, so now that we've seen all the signs, we see that Mrs. HF has congestive heart failure, we've done all these testing, now we want to treat her, manage her. So if you were going to be admitting her to the floor or whatever, what are some of the things that you would want done? You know, what are some of the things you would like? What are some of the things that...
Strict I's and O's.
Strict I's and O's, very important. If you want to keep us happy, strict I's and O's. Very, very important for me.
The daily weight.
Daily weights, very important.
Low sodium diet.
Low sodium diet, okay. Somebody mentioned diuretics. Diuretics, okay.
Something to control that rate.
Yes, rate control. So we also want to make sure that they're getting their vitals every 4 hours, you know, those kind of routine things, continuous telemonitoring, those kind of things. Okay. So basically the first thing about a patient coming in with congestive heart failure is you want to initially assess them, make sure they're oxygenating well, make sure they're ventilating well, you know, continuous pulse ox monitoring. You want to pay attention to their vital signs, make sure they're not hypotensive or hypertensive. They should be on tele. You definitely want IV access. And initially when they come in, it's better when they're in a seated position because with lying down position, you could worsen their symptoms. Of course, we talked about diuretic therapy. We're going to go a little bit into vasodilator therapy. And also very important, strict I's and O's. We talked about daily weights, they're very important. Some of the common diuretics that we're going to use are your loop diuretics, which include, if a patient has a normal renal function, you can usually start with 40 milligrams of IV Lasix. If you don't have Lasix available or they've been on other choices would be Bumex, and you usually start about 1 milligram of Bumex. Torsemide or Demodex is another choice, and that's usually about 10 to 20 milligrams. I tend to use Demodex a lot in patients who are not responding to Lasix. And I think we're not even using Demodex in the hospital anymore. I try to use it once the pharmacy didn't have it. Okay. Now, if patients aren't hypotensive, or if they're coming in with severe fluid overload, you can use vasodilators like nitroglycerin. You can use nitroprusside, especially if the blood pressure is very high, or they're coming in with severe acute valve regurgitation, like aortic regurgitation. And you can also use Neseritide. Okay. We're going to talk a little bit more about ACE inhibitors in the future, but ACE inhibitors are also used in heart failure. We'll talk more about that. All right, so Mrs. HF has been in the hospital now for about 2 days. You have her on large doses of Lasix. She's, you know, urine output's okay, but she's still symptomatic. She still has some signs of volume overload. And her renal function is just getting worse. Her creatinine's going up. Her blood pressure is about 86/60, pulse is 86. EF on the echo is about 25–30%. What can we do here now? So what else? What are the thoughts? You know, any thoughts?
Can we use a BiPAP, you know?
Okay, that's one thought. So BiPAP. Okay, anything else? But my concern about using Zeroxyzine is that the blood pressure is low and also her creatinine is going up. So we're hitting a place where, you know what? And that's good. So we can hold the lisinopril, okay?
Dobutamine?
Dobutamine. So somebody mentioned dobutamine, you know, so dobutamine, and actually, interestingly enough, you would think, oh, the blood pressure will go low because dobutamine is causing vasodilation. But actually, patients with heart failure, as long as they're not in severe shock, when you start the dobutamine, because you're getting increased cardiac output, the blood pressure actually gets better. Yeah, so somebody mentioned dobutamine. Something that we don't tend to use here at Noonan is milrinol. You see a lot of dobutamine, but we also have milrinol. Okay, so let's one slide. So here you are, you've hit a, you know, you're trying all your diuretics, nothing's working. That's when you use your inotropes, okay? Now, what inotropic agents do is that they increase myocardial contractility. And the way they increase myocardial contractility is that they increase intracellular calcium. So right here is your cardiac muscle cell, okay? This is the cell membrane. On the cell membrane, you have beta receptors. When the beta receptor is activated, it causes ATP to be cleaved into cyclic AMP. When you have cyclic AMP, it will cause a rise in intracellular calcium. So with the increase in intracellular calcium, you get increased myocardial contractility. So that's how dobutamine works. Dobutamine will work on the beta receptors to increase your intracellular calcium and therefore increase contractility, okay? Now, the way milrinol works is that, as I mentioned earlier, when the beta receptor is activated, ATP becomes cyclic AMP. Now, after a while, cyclic AMP will be broken down to AMP, which is the inactive substance, by an enzyme called phosphodiesterase. So what milrinol will do is milrinol will block this process. So by blocking this process, what happens? Increased calcium. So with increased calcium, increased contractility, the heart works better. Okay. So as go back, sorry. So as mentioned, dobutamine will act primarily on beta receptors to increase cardiac output. You can use dobutamine in patients with hypotension who do not have clinical evidence of shock. So you can use it in a hypotensive patient as long as the patient is not in shock. Okay? We usually start about 2.5 micrograms per kg per minute, and if it's tolerated, you can gradually increase it to about 15 micrograms. I never go that high. I usually go about 5 micrograms, and I see results from that point. Some of the things that limit it is the heart rate, you know, so sometimes you get really tachycardic. So I wouldn't use it in a patient with AFib because it will just make the AFib worse. So we have that option of, you know, patient is tachycardic, you have the option of milrinone. And as I mentioned, it's a phosphodiesterase inhibitor. It will increase myocardial inotropy by inhibiting degradation of cyclic AMP. Okay? The loading dose of milrinone is about 50 micrograms per kg over 10 minutes. The maintenance dose is 0.375, and you can go to a maximum of 0.75 micrograms per minute. Now, if the patient has renal insufficiency, if they're hypotensive, or if they have arrhythmias, you'll need to adjust the dose. Okay. Now, what if HF had presented differently when she came in? What if when she came in, her blood pressure was about 170/90, heart rate was 126, temperature is 98.7, her O2 sat of room is 82%, and she appears to be in clear respiratory distress. And this is what her x-ray looks like. What is something that we would want to do at this point? Because she's in respiratory distress at this point. So what would be something we want to do, Harold? BiPAP. Yeah, he mentioned it. This is a patient that you want to put on BiPAP right from the emergency room. She's in respiratory distress. You know, so at this point, the BiPAP will be useful to kind of prevent you from having to intubate her. Okay. So we use non-invasive positive pressure ventilation in patients who are in respiratory distress, who have respiratory acidosis, or who are hypoxic. Now, positive pressure ventilation is delivered through a non-invasive interface, like a nasal mask or a face mask or nasal plugs, rather than an invasive interface such as intubation or a tracheostomy. Okay? We use CPAP for patients with acute respiratory failure due to cardiogenic pulmonary edema. We can also use BiPAP. BiPAP delivers both inspiratory positive airway pressure and expiratory positive airway pressure. Now, you don't want to use CPAP or BiPAP in anybody who has just had a cardiac or respiratory arrest. You don't want to use it in people who have non-respiratory organ failure, such as severe encephalopathy, upper GI bleeding, if they're hemodynamically unstable, if they have any kind of facial or neurologic surgery, trauma, or any deformity, you don't want to use CPAP or BiPAP. If they have an upper airway obstruction, if they're not able to cooperate or protect their airway, you definitely don't want to use it. And if they can't clear their secretions, or if you feel like they have an increased risk of aspiration, then you don't want to use that. So what are some of the things that you will be thinking about in terms of planning to discharge the patient? There's certain criteria that you would like to meet before you say this patient is ready for discharge. And of course, you want to make sure you've addressed any of the exacerbating factors, such as if they have an infection, you know, those kind of things. If there are any medications that could worsen this, you want to make sure you've addressed those things. You want to make sure that they have near or optimal volume status. And it's important to have transitioned them from IV diuretics to PO diuretics before you think about discharging. You don't want to discharge a patient who's still on IV diuretics. One thing that's extremely important is patient and family education. So you definitely want to educate these patients. It's important to document the ejection fraction. And you want to talk about smoking cessation, alcohol cessation. You want to make sure that they're at least on an ACE inhibitor and a beta blocker before discharge. And if not, you want to document an intolerance to these agents. And you want to make sure they have follow-up clinic visits. If it's a frequent flyer patient, someone who comes in all the time, or someone who came in with really advanced heart failure, you probably want to make sure they've been on the oral drugs for at least 24 hours. You want to make sure they haven't been on any inotropes for 24 hours. You want to make sure that you ambulate them to assess their functional capacity. And you want to make sure they have good post-discharge management. Things like making sure a scale is present in the home, you have home health set up, and maybe referral to a CHF clinic. So as mentioned earlier, you want to make sure you really give good details regarding their medication. Dietary sodium education is very important. And You want to make sure that they understand their medications and compliance with their diet. Counsel them about alcohol and smoking cessation, and they teach them how to monitor their, their body weight, their electrolytes, and things like that. Okay? So you should really stick to the essential things for education. And the goals are of assisting patients to understand heart failure, the goals of its treatment, and post-hospitalization medication follow-up. Okay? So now you've discharged her, and you'll see her in the office. This is where chronic heart failure management comes into. She feels better, her symptoms improved. What are our goals of therapy at this point? Okay. So the first thing we would like to do when we see her, we want to be able to identify and see if we can correct some of the things that have caused her cardiomyopathy. We want to reduce her symptoms. It's important that we impede the natural progression of disease. We want to improve mortality. That's one of the key things in heart failure is you want to improve the patient's mortality. You want to improve survival. And you also want to make sure that you reduce the need for rehospitalization. Okay? So in terms of treating the etiology, if you find out the patient has coronary artery disease, what you want to do is you want to revascularize that patient either by stenting or by bypass surgery. If it's because of uncontrolled hypertension, you want to control the blood pressure. If it's because of AFib, with AFib and heart failure, you really want to try to maintain sinus rhythm as much as you can. If you can't, then you want adequate rate control. You want to control their lipids. If they have diabetes, you want to control their sugar. Okay. So this is kind of like a general overview of how you want to treat the congestive heart failure patient. You want to make sure you educate them. Education is very important. Address their risk factors. Teach them about salt and fluid vigilance. And the staple for heart failure is your ACE inhibitors and your beta blockers. And you want to titrate these to target doses. If they're intolerant of ACE inhibitors, you can use your angiotensin receptor blockers. If the patient is clinically stable at that point, then you just continue your ACE inhibitors and beta blockers. If the patient is still having symptoms of class 3 heart failure, then you can consider adding things like digoxin, or you can consider adding hydralazine or nitrates. If they're class 3B, then you want to consider things like aldactone. And we'll go more into detail about these medications. Okay? If the patient's ejection fraction is less than 30%, you want to consider referring them for an AICD. If their QRS is wide, you want to consider a biventricular ICD. And if all this fails, you still have the option of transplant, or nowadays we're using what we call the left ventricular assist devices. Okay. So in terms of dietary, sodium and fluid restrictions, you want to restrict their sodium intake to about 2 or 3 grams of sodium daily. If they have severe heart failure, it should be less than 2 grams. If the patient is hyponatremic, you want to restrict their fluid intake to less than 2 liters. Or if they have severe fluid retention, you also want to restrict their fluid intake. A lot of patients ask me about, okay, can I use low salt or no salt? The problem with no salt or low salt that they sell is that they replace the sodium with potassium. You don't want to be giving CHF patients anything that has potassium. So that's why I always tell patients, stay away from low salt or no salt. Because they say low salt, oh, I think I can use it, but you tell them it's not a good idea. Now we're going to go through the individual drugs for heart failure. But I think to really, really understand how these drugs work, I think we need to understand the pathophysiology of congestive heart failure. How does heart failure cause problems? Because if you understand that, then you understand why we use these drugs. Yes, ACE inhibitors and beta blockers are blood pressure medicines, but we're not using them for blood pressure lowering heart failure. We're using them for other things in heart failure. So let's start here. So in congestive heart failure, you have a decreased cardiac output. When you have a decreased cardiac output, the kidneys are seeing decreased flow. And in response to that, they'll activate 2 systems. We call this the neurohormonal systems. They'll activate your renin-angiotensin system, and they'll activate your sympathetic nervous system. And what this does is that the renin-angiotensin system will ultimately lead to retention of sodium and water. The body's thinking, oh, I'm helping out here. I'm getting less fluid to the kidneys. Let me retain more water. So you'll get sodium and water retention. The sympathetic nervous system will cause vasoconstriction, so you get increased heart rate. And what that does is, so with the renin-angiotensin system and the sympathetic nervous system, you're going to get increased heart rates, you're going to get increased systemic vascular resistance, and that's from vasoconstriction. And you're also going to get increased preload, and that's from the sodium and water retention. And what happens is that that's just going to stress an already stressed heart. So with heart failure, we need to stop this. We need to prevent this vicious cycle from occurring. So we have to target it. And where we target it is right here. We want to block the activation of these two things, the renin-angiotensin system and the sympathetic nervous system. Beta blockers block the sympathetic nervous system. So that's the role of beta blockers in heart failure. It blocks the sympathetic nervous system. So let's put next slide. This is the renin-angiotensin system. So what happens is when the kidneys see decreased blood flow, the renin-angiotensin system is activated. What happens is angiotensinogen will be cleaved to angiotensin 1. Angiotensin 1 will become angiotensin 2 by this enzyme called your angiotensin converting enzyme. Now, angiotensin 2 will cleave to the receptors, will cause vasoconstriction, and will also cause the release of aldosterone. And what aldosterone will do is it will increase sodium retention and also increase fluid retention. So, like, if we can stop this process, we can prevent the vicious cycle that occurs in heart failure. So basically, this is where your ACE inhibitor comes in here. The ACE inhibitor will prevent angiotensin 1 from becoming angiotensin 2 and therefore stop that sodium. Your angiotensin receptor blockers like your Diovan, your Cozar, losartan, they will prevent the angiotensin 2 from cleaving to the receptors, and also by doing that prevent sodium and fluid retention. And then you have your aldosterone inhibitors. Those are your spironolactone, aldactone, Inspira. They will prevent the secretion of aldosterone and thereby prevent sodium and water retention. Okay? Sorry. So let's start with our ACE inhibitors. Like I said, your ACE inhibitors are still your first-line therapy for all patients with systolic dysfunction. And it's important that when you start it out, you want to get them to target doses. You have to titrate it to target doses. If patients are intolerant of ACE inhibitors, then you can use your angiotensin receptor blockers. And for the most part, patients are usually intolerant primarily because of a cough or angioedema. And the reason you get the cough is that this angiotensin enzyme right here causes bradykinin. You have bradykinin in the body. Bradykinin is broken down to its fragments by ACE. ACE inhibitors will prevent this from happening. So you get a buildup of bradykinin, and increased bradykinin in the lungs will cause a cough. We use various ACE inhibitors. We use captopril, enalapril, ramipril, lisinopril. We usually start out about 2.5 to 5 milligrams, and our goal is to titrate these patients to 20 milligrams, as long as they can tolerate from a blood pressure standpoint. So the goal is to get them to target doses. Okay. If the patient is intolerant of an ACE inhibitor, either due to cough or angioedema, then you can use your angiotensin receptor blockers, such as your Diovan, Avapro, or Cozar. And again, you want to strive to get them to target doses. Beta blockers. Beta blockers are recommended for all stable patients with current or past symptoms of heart failure and a decreased ejection fraction. The benefit of beta blockers is that they improve survival, and they also reduce hospitalizations. You don't want to use beta blockers in people who have reactive airway disease such as asthma. You don't want to use it if they're bradycardic, and you also don't want to use it if they have symptomatic hypotension. There are only 3 beta blockers that have been proven to increase survival in congestive heart failure. They are Coreg or carvedilol, metoprolol XL, not just plain metoprolol, it's metoprolol XL, and bisoprolol. And with carvedilol, you want to start with 3.125 milligrams twice a day, and then you want to titrate. What we do in the office is we bring them in, we start at 3.125, and we bring them back every 2 weeks, and we try to titrate them to a goal of 25 milligrams twice a day. That's when you get the maximum benefit. Some patients, we can't get them there, but we try as much as we can. Okay. So of course, we know how beta blockers work. They block by inhibiting this sympathetic nervous system. And it's important that you educate the patients about beta blockers. It's important to titrate them like we talked about. And if a patient comes in with congestive heart failure, like our patient who first came in, Mrs. HF, you know, if she comes in heart failure and she's not on a beta blocker to begin with, and you need something for blood pressure control, would you use a beta blocker? The answer is no. If a patient comes in with severe heart failure and they're not on a beta blocker, you don't want to start on a beta blocker until they're compensated, because it can actually make them worse to begin with. So if a patient is coming with acute decompensated heart failure and they're not on a beta blocker, don't use it for blood pressure control, because you can make them worse. And the reason you make them worse is, think about it. We talked about beta contractility. If you're blocking the beta blocker, you can decrease the contractility of the heart to begin with. So you want to wait until they're stable, they're compensated, then you can now add your beta blocker. So in acute decompensated heart failure, if they don't have a beta blocker on board, don't use it. What about if they come in on a beta blocker? Do you take them off the beta blocker? No. You continue it, because they've already been on it. Sometimes if they're in severe heart failure, you may want to kind of decrease the dose, but you don't stop it. Okay. And you don't want to use beta blockers in patients who come with cocaine abuse. Makes it worse. So now we have our aldosterone antagonist. And remember, we talked about in that pathway, aldosterone is the last step that causes retention of sodium and water. So we want to try to attack that process. And we use aldosterone antagonists like our aldactone, spironolactone. We have a newer drug out now called Inspira, which you probably won't see much use in the hospital because it's just so expensive. So we don't use it. So spironolactone or eplerenone, that's Inspira, that's the one I was talking about. The indications for using this would be in a patient whose ejection fraction is less than 35%. You can add it to an ACE or a beta blocker if they're still having symptoms and they have New York class 3 or 4 failure. You have to be careful with aldactone because it causes potassium retention. So you have to closely monitor the potassium, and you want to avoid potassium supplementation. So basically, if you have a patient who's on aldactone and Lasix, you probably don't need potassium supplementation because that patient is going to be getting the potassium sparing from the spironolactone. You don't want to use it in anybody whose creatinine is more than 2.5 in a man or 2 in a woman. And if the potassium is more than 5, you probably don't want to put them on aldactone because they can get more hyperkalemic. Okay. Your diuretics, of course, those are your Lasix and things. We use them in combination with ACE inhibitors, and we use it for symptoms of fluid overload. The benefit of the diuretics is you get rapid improvement in symptoms. We usually prefer your loop diuretics like Lasix, Bumex, or Demodex. If you're going to use higher doses, you want to divide it into either a 2 times a day dosing or a 3 times a day dosing. And if the patient is still fluid overloaded, someone had mentioned Zeroxylin, you can add Zeroxylin on board as well. But you don't want to be using Zeroxylin on an everyday basis because you can make the renal function worse. So you can just use it maybe 2 or 3 times a week. Okay. So we talked about loop diuretics. We prefer to give you Lasix rather than metallazone or thiazide. You want to give it 2 to 3 times a day. It's important that you include family education, and you can titrate these drugs. So if a patient is having increased weight gain, maybe a 2 to 4 pound weight gain in a 24-hour period, you can tell them to take an extra dose of Lasix. Okay? Now, there's drugs called hydralazine and oral nitrates. These are used in patients who can't tolerate ACE inhibitors. I think I'm going to try to draw something here. So basically, the way ACE inhibitors work is that this is the heart. The venous return to the heart is called your preload, right? And your afterload is on the arterial side, especially when you have constriction. So what ACE inhibitors do is they're vasodilators. So that when you dilate, you're going to get decreased afterload. When you venodilate, you're going to get decreased preload. So the way hydralazine and nitrates work is that they work in combination to act like an ACE inhibitor. For example, hydralazine will work on the arterial side to cause arterial vasodilation, therefore you get decreased afterload. The nitrates will work on the venous side to cause venodilation, so you get decreased preload. So in a way, hydralazine and nitrates are like an ACE inhibitor, but combined together. And the advantage of that is that you don't have to worry about the renal creatinine increasing or hyperkalemia that you would get with ACE inhibitors. So if you have a patient that can't take ACE inhibitors because of renal insufficiency, that's the patient that you want to use hydralazine and nitrate combo on. Now, hydralazine and nitrates have been shown to improve survival as well, especially in your African American population. They're very beneficial. So what I've done with hydralazine and nitrates, if I have a patient who's on an ACE inhibitor, on a beta blocker, yet they still have class 3 or 4 symptoms, that's when I'll go ahead and add my hydralazine and nitrates. So rather than going to something like Norvasc that has absolutely no benefit, if you need blood pressure control, you probably want to use a hydralazine and nitrate combo before you would go to another agent. Okay? And usually the starting dose of hydralazine is about 37.5 and Imdor 20 milligrams. And you do it 3 times a day, and you want to titrate up to 2 tablets 3 times a day. Let's talk about digoxin, okay? Digoxin has no survival benefit, but it decreases your symptoms and also decreases hospitalization. How does digoxin work? How does it help the heart? And the way it works is that normally you have what we call the sodium-potassium exchanger, and what that does is that when you have that sodium-potassium exchange, you end up getting calcium being released from the cells. Digoxin will block that sodium-potassium exchanger. So by blocking it, you get increased calcium, increased contractility. So that's how digoxin works for the heart. So you don't want to give digoxin to someone who has diastolic heart failure. So diastolic heart failure, the EF is normal. We don't use digoxin in those patients. It's only for people who have systolic dysfunction. And I don't add digoxin unless this patient is coming back and forth in the hospital and they're having increased symptoms. The usual dose of digoxin in congestive heart failure is about 0.125 milligrams daily. Kevin asked me to talk a little bit about calcium channel blockers. He said, what is the role of calcium channel blockers in congestive heart failure? Do we use it at all? At first, everybody said if you have a decreased ejection fraction, you should not have this patient on a calcium channel blocker. And that's still the case. If I have a patient whose EF is low, I don't want calcium channel blockers. But it's not all calcium channel blockers. There are 2 types of calcium channel blockers. You have your dihydropyridines, which are your verapamil and your cardizem. Those will decrease contractility. So you don't want to use it in patients who have decreased ejection fraction. But things like Norvasc, which is amlodipine, they don't act on the ventricle. They actually act on the arterial side to cause vasodilation. So you can use those. There's no mortality benefit with them, but basically there's no direct role for these drugs in heart failure, but you can still use Norvasc. But you don't want to be using cardizem. You don't want to use verapamil because it's going to decrease contractility. You can use it in diastolic failure, but not systolic failure. Okay. So what is the role of ICD? Why do patients with congestive heart failure end up getting an ICD? Anybody who has an ejection fraction of less than 35% will benefit from an ICD. And it's for primary prevention of sudden cardiac death. That's all it's for. It's not for symptom improvement. It's to prevent sudden cardiac death. And you don't want to use an ICD in anybody who you think their survival of, in 1 year, if you have the decreased survival in 1 year, you don't want to use it. A 95-year-old who comes in congestive heart failure, who has a decreased EF, that's not a patient you want to put an ICD in. Or a patient that has cancer, has only less than 1 year to live, you don't want to put an ICD. Basically, it's for patients who have good functional status and what you expect the survival is going to be long. Those are the patients you want to put an ICD in. And the ICD, basically, you have a lead in the atria and a lead in the ventricle. And what it does is that if a patient comes in with an arrhythmia, it'll deliver a shock. Okay? Sometimes you see patients who come in with what we call a biventricular ICD. What's the difference between an ICD and a biventricular ICD? The difference is in the number of leads. In an ICD, you have a lead in the atria in the ventricle. With a BiV, you have a lead in the atria, one in the right ventricle, and you have another one that goes to the left ventricle. And the reason for this is that in patients who have a wide QRS, there's dyssynchrony. The right heart's pumping, the left heart's pumping, but they're not pumping in sync. So by using a BiV ICD, you're allowing the right ventricle and the left ventricle to pump in sync. You get better pump function. So any patient who has an EF of less than 35% that you're considering for an ICD, if they have a wide QRS, you probably want them to get a BiV ICD. And those patients actually do better because they get increased cardiac output because good pump function together, better cardiac output. But not everybody qualifies for a bi-VICD. You have to have a QRS of greater than 120 to qualify for that. I'm going to touch a little bit on diastolic dysfunction. As I mentioned before, diastolic dysfunction is a preserved ejection fraction. Some places you see 40% as being cut off, some places it's 50%. But it's patients who have a preserved ejection fraction. So it's also called heart failure with a preserved ejection fraction. With these patients, you want to evaluate them for ischemic heart disease because that's a very common cause of diastolic dysfunction. You want aggressive blood pressure control. You want a low sodium diet. If they're in AFib, AFib is not good for diastolic dysfunction. You want to make sure they're in sinus rhythm, and if you can't get them into sinus, control their heart rate. You want to consider diuretics for the symptoms of pulmonary congestion or peripheral edema. If they've had a prior MI or they have AFib or hypertension, you want to use beta blockers. Again, not in the acute phase, but when they're compensated. The use of beta blockers, ACE inhibitors, ARBs, or calcium antagonists in those patients will minimize the symptoms. So you can use calcium channel blockers with preserved EF. So now we're going to have a summary of my whole entire presentation. So basically, if a patient presents with acute heart failure, you send them to the ER. If the patient has severe heart failure or chronic heart failure, they definitely want to be seen by specialists. And you probably also want to refer them to a congestive heart failure clinic. And for all patients who have a decreased ejection fraction, you want to educate them. Education is very important. Aggressive risk factor modifications. If they have diabetes, you want to control diabetes. If they have high blood pressure, you want to control that. If they have hyperlipidemia, you want to treat that. Lifestyle modification, you want to tell them to quit smoking and also quit alcohol. You want to teach them about salt and fluid vigilance, and you also want to tailor their diuretics. If they gain weight, extra diuretic. The mainstay of treatment are your ACE inhibitors and your beta blockers. If they can't take an ACE inhibitor, and the reason would be for what? Cough or angioedema, what else can they use? If they can't take an ACE inhibitor, yeah, they can do hydrazone nitrate or they can do an ARB. So usually you want to start, if you have an ACE inhibitor, if they can't take an ACE inhibitor because of cough, you want to use ARB. If it's because of renal insufficiency, that's where the hydralase and nitrates will come into. Once you started them on that, you want to titrate them to target doses. Once you get them to target doses, they're doing fine, they feel great, you're done, okay? But if they come back and tell you, you know, doc, I'm on this max dose of ACE inhibitors, beta blockers, but I still don't feel good. That's when you'll consider adding digoxin, for example, or you can now add hydralase and nitrate. And if they're class 4, they can't get from one place to another, they're still fluid overloaded, then you can add your aldactone, okay? And of course, you want to consider ICDs. If their EF is less than 30%, if their QRS is more than 120, you want to consider bi-VICD. And if all else fails, ship them to Piedmont.
I was going to ask about that because they give a lot of Nature over there. Can you
Yeah.
talk a little about Nature?
Yeah, you know, Nature Core, when it first came out, everybody was using Nature Core. It was like the big thing. Then there was a study that came out, I think it's called the Ascend study. And what they found was the benefit of Nature Core was not as much as we expected. There were issues with hypotension, issues with renal insufficiency. Nature Core is a vasodilator. So what it does is it vasodilates, and it also causes natriuresis, decreased sodium, decreased volume load. But the problem with Nature Core is you get a lot of hypotension with it, and you also have issues with renal insufficiency with it. So those are the reasons why it kind of fell out of favor, because the benefits were not as much as we expected. When all the studies started coming out, the studies were not as favorable, and that's why it kind of fell out of favor. But they still do a lot of it up at Piedmont.
Yeah, they give it in the clinic, and I guess it's not available in any other form than IV.
IV, yeah.
It's sort of like, well, when do you have a patient who, have you exhausted every other option when they're coming into the clinic every 2 weeks for Nature Core?
Nature Core, yeah, exactly. And some people some other patients come in for Nature Core, they come in for dobutamine or Mironol. None of these things have been shown to improve survival. It's really more for symptom management. Yes.
What's the difference between an ACE inhibitor and an ACE receptor blocker when it comes to angioedema?
Actually, you're not really supposed to have the angioedema with the angiotensin receptor blockers, but I've seen a few percentage of patients who develop that.
We've seen it.
Yeah.
In the last 6 months, I know we've had two people come in and
yeah.
intubated, and ICU. With,
and they're on ARBs.
With it.
Yeah. You know, but so that for me, if a patient has angioedema with an ACE inhibitor, I'm not going to use an ARB.
Okay.
You know, because we've seen a few cases of the angioedema.
So at what point would you, if you have a CJ patient that's also hypertensive, where's your cutoff for saying, okay, I'm only going to use the Lasix for symptom control and not use the beta blocker and ARBs?
Yeah, definitely I would, with the hypotension issue, you don't want to use, I would go with withdrawing the beta blocker before I do the Lasix. And it kind of depends on their volume status. You can kind of tell. The question is, are they getting hypotensive because you dry them out too much? So you have to look at the patient clinically and say, okay, if this patient is euvolemic, you probably want to withdraw the Lasix. If they have still pitting edema, things like that, you either want to decrease your dose of the beta blocker. Yeah. So one of the questions Kevin asked me to address is, when do you hold your ACE inhibitor? When do you hold the beta blocker without making the cardiologist mad in the morning? Then why did you hold that? You know, most patients with heart failure tend to tolerate blood pressures in the 90s very well. And actually, the ACE inhibitors actually help. What they're doing, like I said, is vasodilating, increasing contractility. So they actually can tolerate those blood pressures. I have the patients with blood pressures in the 80s. You know, so they tolerate it pretty well. So I would say you don't want to hold it, you know, if the patient's blood pressure is 90 or more systolic. Because at home,
Symptoms?
if they're symptomatic, yes. Yeah, if they have symptomatic hypotension, you hold it. But if they're not symptomatic, at home they're taking this all the time, you know, and they have no problems. So you don't want to hold it unless they're symptomatic and the blood pressure is in the 80s.
You spoke about the heart failure clinics.
Yeah.
Is there a clinic
There is,
here?
not in Noonan, there's a heart failure clinic at Fayette that has been there for the last 2 years, and they've done a very good job. They have a nurse practitioner who's very well trained. She'll spend an hour with the patients. She has all these things that she teaches the patients about sodium management, what foods to eat, what foods not to eat, because it's all about education. So, and then they also do outpatient therapy like intravenous Lasix in the heart failure center. We're not doing nature core at Fayette, but you know, we do IV Lasix over there.
So when you have the ones that the frequent flyers that come
Yeah.
in for CHF
Yeah.
that are coming here to Noonan and
Yeah.
they don't qualify for home health care,
We send them to the heart failure clinic.
you send them over there.
What I've had though is a lot of my Noonan patients will not want to go to Fayette. They have one
Right.
reason or the other why it's just too difficult to go over there. So we really need a heart failure clinic down here because we know that heart failure clinics have decreased hospitalization in a lot of patients because when they're getting a little symptomatic, they go to the heart failure clinic, they get their Lasix, and they're okay.
Right.
Any other questions?
Will they possibly do one at the new hospital?
I
Or
suspect
with
that,
the-
yeah, we probably will have a heart failure center here.
Thank you so much.
Thank you very welcome. I want to thank Sybil Whitesell because she's responsible for all the nice fancy pictures that we have here. Okay. Thank you. Oh, thank you.